So very good evening to all of you for this 19th online teaching class under the banner of UP chapter of Up-Aroi. And today we are having the second class under the session of the breast cancer management. For this we are having the two famous and very known personality with us, Dr. A.K. Chaturvedi sir and Dr.B.Paul Thaliath sir, and Dr. Shalin sir also is the president of Up-Aroi. So to start with, I would like to introduce Dr. A.K. Chaturvedi, though he does not require an introduction, but as a courtesy, I have to introduce him. So Dr. Chaturvedi sir is the director of Dr. Chaturvedi Cancer Institute and Research Center in Gorakhpur, and is a very dynamic personality. He is doing so much of social work also for cancer prevention. So sir, it is over to you.
Thank you, Dr. Shri, for your generous words. And today we are discussing about brachytherapy and breast cancer. And this is very important topic for the undergraduates level as well as for the practicing persons. Today we have very eminent speaker, Dr.B.Paul. He needs no introduction. He needs no, I think everybody knows him. And he's Padam Vibhushan. And he is director of Kamla Nehru Hospital, Prayagraj. And I think he's there since beginning of this radiotherapy department. And he has done a lot of work in that hospital. And he's very much keen in doing interstitial implants. Because I remember in Uttar Pradesh, earlier nobody was doing. He has started, restarted rather, quite a long back. And I used to refer cases to him for tongue implants. Breast implants, though I have not referred, but he's good in both. So today, our talk will be on interstitial implant on breast cancer. So I invite Dr. B.Paul without further delay. He can start his speech.
Thank you, Dr. Chaturvedi, the chairperson. I'll be just giving some indications of brachytherapy in breast cancer.
Right.
Then mainly we'll be discussing about the role of interstitial brachytherapy. Then there are some role of using intracavity implants. So usually we do it perioperative. And there are some novel methods also available. And there are some other indications where brachytherapy is used. Where we have tried, again, we have a postgraduate thesis where you are used in locally advanced breast cancer, LABCs, where it was not operable, initially operable. We had gone for neoadjuvant chemotherapy. Subsequently, we have found to have these patients, some of them suitable for the implant, the BCT, breast conservative treatment. Then further, we have done the brachytherapy for such cases. So I'll be just discussing these indications in a series. Yeah, brachytherapy in the conservative managed. Can you see all the slides, everyone?
Yes, sir.
Yeah,
See the slides? Yeah. So brachytherapy in the conservative management of breast cancer, the indications of brachytherapy as a sole modality. In sole modality, when you use brachytherapy, the treatment time will be very short. We can complete the whole treatment in about few days treatment, 4 to 5 days. And because we'll be giving twice a day treatment and in a higher dose, and then the whole treatment is done in a very short time. So people come from far off places, can go back to their work. People, the old age people, they don't have to stay in the hospital for a long time. And elderly and frail and poor health people, they get a short treatment. And patients who are breasts which are sufficiently large and they have unacceptable toxicity with the external beam radiation, they can be given this brachytherapy as a sole modality. There are indications for brachytherapy as a boost to the external beam radiation. That is mainly for patients with close, positive, or unknown margins after conservative breast management. For patients with extensive intracranial components, and for younger patients, we'll prefer to give by external beam radiation, then doing the brachytherapy boost. And for deep-seated tumors in a large breast, again, we prefer to do external beam radiation followed by brachytherapy. And for the CTVs, which are irregular in thickness, we also prefer to give the treatment by external beam radiation, then boost by brachytherapy. So as you all know, majority of the breast relapses occurs at the index quadrant of the breast. SGF brachytherapy is a labor-intensive, cosmetically demanding, but dosimetrically excellent alternative to deep-seated tumors, especially more than 3 centimeters from the skin. So we can deliver a conformal radiation to the target volume we define by doing meticulous planning. And we have seen less than 20% of the local recurrence occur elsewhere in the breast. This is equal as developing the breast cancer in the opposite breast. Yeah. External beam radiation is the standard radiation modality used after lumpectomy in the conservative management of breast cancer. And we have seen about 15 to 30% of breast cancer patients after the breast conservative treatment, they are not getting the radiation for various reasons. Some are reluctant, some are scared of the disease, and some of them, the surgeon is overconfident that they have done a clear margin. The margins are clear, so they don't agree for a further radiation treatment. So about 15 to 13% patients, they don't get the radiation after breast conservative management. And now there is increasing employment of brachytherapy as a sole modality of treatment, where we can give a higher dose to a confined localized area. Then the current status of accelerated partial breast irradiation. It is not well defined. The accelerated partial breast irradiation not just validated through randomized clinical trials, but in low risk cases, the accelerated partial breast irradiation outside the context of a clinical trial is acceptable. But in high risk group, it is not, it's a contraindication. But in an intermediate risk group, accelerated partial breast irradiation considered acceptable only in the context of a prospective clinical trial. Yeah, coming to the role of brachytherapy in cancer breast. It can be used as a boost therapy in BCT after a dose of 45 to 50 gray by external radiation to the whole breast. A boost can be given about 15 to 20 gray delivered by brachytherapy. It can be used as a sole modality of treatment, an alternative to the standard BCT in selected patients. For treatment of the chest wall recurrence, rarely we come across chest wall recurrence after mastectomy. Patient after given radiation and other subcutaneous treatment, chemotherapy, patient may come with chest wall recurrence. Again, it may not operable. Then in these cases, they can be irradiated with specific mold casts we can use, or in rare selected cases, we can do even interstitial implantation. Then another indication again is the locally advanced breast cancer. I said, in inoperable locally advanced breast cancers, we have taken a trial also in the hospital. There we have compared this patient after neoadjuvant chemotherapy. Those who are operable, we have taken up a surgery. We have done the breast conservative surgery and subsequently given the radiotherapy. And I'll come to it later. So discussing about the interstitial implantation. See, the interstitial implantation in breast cancer, we can have a direct visualization of the lumpectomy cavity and the clips during the surgery, where it can be done perioperatively, the intraoperative procedure, and we usually use a freehand method. After catheter placement, wound is closed and the position is secured. Then we have a closed cavity implant, that is after the mastectomy of breast conservative treatment, after the wound is sealed, after the final pathology information to the gate is and appropriate patient selection is done, and we can decide about the methodology to be employed. What type of implant you have to do? We have to select the dose, select the target area, and accordingly we can give the do the interstitial implantation. So open method where you do it perioperative, other is after the breast conservation treatment. So this is a multi-plane implant we have done, 3-plane implant, and you can see, you define the target volume, you can mark it out with the imaging technology, and precisely we can load the dose to the different catheters and get a good target. The disease, margin, you have to take a define the target and deliver the dose to that particular area, so that we can If you see the configuration of the doses, we can keep the skin away from the tumor, and the chest wall is also spared, and the deep-seated tumors, deep-seated structures like the lung and heart will get the minimal radiation. So we can precisely deliver the dose to the target volume by this interstitial implantation by using usually a multi-channel implant. So the catheter implantation, either it's a freehand technique or we can use a template for this. Under the imaging guidance, if you need the image guidance, we can use the ultrasound, fluoroscopy, CT, or a multimodality imaging can be used. So the design for the implant and the geometry. Needles are implanted equidistant and parallel to each other according to the Paris technology system. In most cases, and this needles are implanted from medial to lateral direction. And in a very medially or very laterally located tumor, usually needles should be implanted craniocaudally to enable the separate target area away from the skin points to spare the higher dose to the skin and the skin necrosis. In some rare cases, the outer quadrant of the breast, the implant is done in about a 45-degree angle to avoid overlap of the source positions and sparing the skin. Two plane needles are usually needed to cover the PTV. A single plane implant can only cover about 12 millimeters target area. Usually 3 planes are required in a large breast where the targeted breast tissue between pectoral fascia and skin is thicker than 3 centimeters. Usually about 5 to 9 needles are required for spacing the making a 3-plane implant. So here you can see the different type of implants. The upper 2 slides are of the template implants we have used. That template implant, the advantage is we can have the catheters given in a specific in the equidistant space, and the target volume will have a uniform target volume. Again, the dose can be delivered in a uniform dose delivery can be applied. And in the catheters, other loose implants, we can have the open end catheters are there, and the double button type of implants are there. The catheters are there. And this is the technology where you use the implant perioperatively. We can introduce the catheter using the clips applied by the surgeon, or doing the operative procedure also. We can observe the thing, and at the margin of the lumpectomy cavity, we can put these catheters. And this catheter, after assuring the proper position of the catheters, then the wound is closed. In this method, actually, we can deliver precisely the dose at the margin of the lumpectomy cavity, where you expect the maximum recurrence of the tumor. So we can precisely deliver the maximum dose to the targeted area, specifically sparing the skin, superficial skin, the deep chest wall, and the deeper structures. So the reduction of the skin dose can be done by compressing the applicators, the template applicators, so that the skin is spared. I'll come to it later. So the advantages, the longest follow-up we have seen, better control and tailoring of the radiation dose, delivery to variations of the lumpectomy cavity, shape and location within the breast. And it limits the toxicity to the healthy tissue while delivering the maximum dose at the risk tissue. Critical structures can be avoided by differential loading in the catheters of the brachytherapy. The disadvantage of implant, again, considerable training and experience is required. Care is required to ensure adequate source to skin distance. Not a viable treatment option for patients with superficial tumors or patients with small breasts. So you can see brachytherapy as a sole modality has been tried by various authors, and it has been reported and presented. And if you see the various SDR procedures done by the SDR alone, or SDR used as a boost. We find the local recurrence rate is slightly higher when it was used as a SDR alone, but it was much superior when you are used as a SDR boost. The local recurrence was found to be less. And the good and excellent cosmetic results were obtained, especially when the SDR was used as a boost treatment. Then the interstitial brachytherapy, the main advantage lies in the ability to give the tightly conformal dose to the specific volume. Used as a boost following BCT along with external beam RT. Now being tried as a sole modality after lumpectomy in breast conservative treatment. Clinical situation where breast brachytherapy may be used more useful than EBRT. There are the advantages are in the large breast, deep-seated tumors, or when there is an extensive intraductal component. The brachytherapy will be superior than external beam radiation. The boost by the Iridium 192 SDR, we have to define the target volume, the pre-treatment identification of the sequences of the catheter, and then you have to take a decision regarding the planes of implants, and then we do the 3D reference volume. And the method adopted is again under the anesthesia, you have to define the target area, the biplanar implant, the post-implant orthogonal radiography, and the CT. And then we do the 3D plateau planning, TPS planning, then define the DVH and the isodose, and they do the 3D matching. Actually, we have manual offloading devices as well as remote offloading devices. So nowadays we use mostly the remote offloading devices. The industrial applicators also we have open and closed and one with a double button also, usually introduced into the tissue via open end needle, and these catheters are usually flexible. And this is the high dose brachytherapy system we use. For the accelerated partial breast irradiation, brachytherapy of the breast cancer can be used after lumpectomy, either as a boost to the external beam therapy or as a monotherapy. Two major techniques are applied. Needles are inserted interstitially into the breast using a template with either LDR or SDR. An applicator is inserted into the cavity and expanded so as to make the cavity roughly spherical, and the SDR hose is stepped through the applicator. This I'll come to it later. So this is the template method you use for each patient according to the size of the breast and the size of the tumor, the target volume you have to define. We can choose the size of the template, and here use a large template. The biggest advantage you see here is we can spare the skin by compressing both the templates together. So the skin surrounding can be spared and the dose to the skin can be minimized. So this is the interstitial needle technique I've already discussed. They can implant to the tumor perioperatively, you can do it, and the tumor, the target volume can be defined, and excessively we can give the margins of the resected lumpectomy cavity can be irradiated to a higher dose. The typical accelerated partial breast irradiation brachytherapy doses are the LDR we used to use 45 to 50 gray at about 0.5 gray per hour. The SDR we use 34 gray at 1 centimeters outside the cavity wall in 10 fractions, that is 2 fractions per day. The brachytherapy quality assurance. The quality assurance is very important, needed for assure, and the safety of the patient is important for the safety of the public and the staff. The postural accuracy, the temporal accuracy, and the dose delivery accuracy is important. And we have various guidelines, the astro brachytherapy guidelines that we are following to take the precautions. And the general flow of the brachytherapy procedure. First is we have to select the patient, the ideal patient for treatment for brachytherapy you have to choose. Then you have to review all the medical and technical documents and do the pre-planning. The pre-planning, you have to take a decision about the application technique, the type of applicator, the geometry, the dose constraints, so the critical structures we have to see. Then usually the procedure is done under anesthesia. Then you have to see the quality assurance of the equipments. You have to do the daily checks of the equipments, the visual inspection of all the applicators before the procedure, availability of dosimeters, emergency equipments during the procedure. Then you have to do the application with or without image guidance using X-ray, ultrasound, CT or MR. Then after done in the implant, we have to do the localization imaging. That is either done by the X-ray images, drawing with the reference points, and you have to mark out the ICRE points and reconstruction of the geometry with the treatment planning system. Then you have to do the sectional image by the MR or CT, whichever is applicable, and transfer the images to the TPS. And the TPS, you have to delineate the target volume and the organs at risk. The treatment planning then is done based on the dose prescription, the reference points, dimension of isodose, and the DVH constraints you have to take into consideration. Then you have to do the validation of the plan. A joint decision between the team, the clinicians as well as the physicists has to be done, and a double check of all the essential parameters has to be taken. Then you have to execute the treatment. The radiation treatment, we have to connect between the applicators and the afterloader and in vivo and do the dosimetry, and adequate nursing care has to be taken. And then after the completion of the treatment, you'll have to do proper documentation of all the technology, how it is done, and what are the dose delivered, what are the documentation is important procedure. So if we come across, there are various studies that taken by the Milan study, the Sweden study, the Ontario study, and the British trials has been done, where they used surgery alone, their surgery with radiation technique, radiotherapy. So we have seen whenever there is a radiotherapy is added to surgery after the breast conservative treatment, when the radiation was added, always the patient, the local recurrence was significantly reduced, and it was reduced in whenever there's a subsequent radiotherapy added to the breast conservative treatment. Significant reduction in the recurrence rate was observed in all these various studies we have done had been done earlier. So as you all know, the rationale for the accelerated partial breast irradiation, I've said 90% of the relapses in the breast resides at the lumpectomy area, cavity, or the index quadrant. The lower probability of subclinical microscopic disease with increasing distance from the primary. The higher doses can be given to the smaller target volume, shorter treatment lengths, and less tumor repopulation is there. Whether patients undergo radiation or not, the risk of relapse outside the primary site is the same as in the contralateral breast. The whole breast radiation might appear to be little over treatment in many cases. So the rationale along with clinical desire to lead to investigation of accelerated partial breast irradiation to shorten the radiation course of radiotherapy. As you all know, there are sufficient brachytherapy, the radiobiological support. The hypofractionation can improve the therapeutic ratio. So accelerated partial breast irradiation, advantages of the whole breast irradiation is shorter treatment times. That is, the whole treatment is completed in 4 to 5 days, whereas the external whole breast treatment takes about 3 to 8 weeks. Then there is always a better quality of life, shorter waiting list in busy departments, and less side effects in both the breast, lung, and to the cardiac area. So according to the American Breast Cancer Society, American Breast Brachytherapy Society, the criteria for selection of patients are age more than 45 years, the size of the tumor should be less than 3 centimeters, histology, It was applicable for all invasive types of tumors and DCIS. The estrogen receptors are either positive or negative, and the surgical margin should be negative, and there should not be any lymphovascular invasion, and the nodal status should be negative. And the update by the Astro, it has been seen, they have said the age should be more than 50 years, the grade 1 to 2 disease, tumor size less than 3 centimeters, the hormonal status ER positive and HER2 negative, the node should be negative, and the margin should not be more than 1 millimeter positivity. So these are the cases not suitable for accelerated breast partial breast irradiation. That is the pathological factors. The tumor size more than 3 centimeters. The T stage TN4. The margins positive. Lymphovascular invasion extensive. Multicentricity and multifocality of the disease more than 3 centimeters. And poor DCIS if it is more than 3 centimeters in size. And extensive the extensive intraductal component is more than 3 centimeters size. So again, not suitable for partial breast irradiation, age less than 50 years. The BRCA1 and 2 mutations are present. Nodal factors, end stage is positive, N1. The nodal surgery if not performed. For the treatment factors, neoadjuvant therapy if used, again, we will not take it for the accelerated partial breast irradiation. The treatment modalities available with us are interstitial brachytherapy, we have already said, the low dose or the higher dose. Then the intracavity technique, we are using orthovoltage photons, intraoperative electrons, and or by the brachytherapy. The external beam radiotherapy is by the 3D conformal photons or mixed beam. Then you can use the IMRT, or even you can consider for proton treatment. So why brachytherapy? That's the question today for breast cancer. What are the advantages of our external beam RT? As I already discussed, brachytherapy is the most conformal type of radiation therapy. We can deliver less dose to the healthy normal tissues. The no CTV to PTV expansion. That is, PTV is equal to the CTV. The smaller volume of normal tissue irradiated to high doses. Fewer challenges due to setup variations and respiratory motions. So there is no problem with the movement or the variation with the respiration. So the dose profiles with target movement is with the SDR, we can get more conformal radiotherapy to the selected area. There have been various publications, I said. The ESTO publication were given 5-year results of accelerated partial breast irradiation with whole breast irradiation in a large series of patients, taking about 1,300 patients, about 600 each in arm. About 600 have been given whole breast irradiation, and about another 600 given partial breast irradiation. And some cases were excluded during the study time. And if you see the results, long-term results, it has been seen the ipsilateral tumor recurrence. The same, the recurrence was slightly, marginally more in the accelerated partial breast irradiation compared to the whole breast irradiation. So it was just marginal. The overall survival was same, similar in both arms, and the disease-free survival was also similar in both arms. And 50 the 5-year and the late side effects, and both were comparable in each the various grades, the skin, the deep structures, the grades were all similar. And when you discuss about the cosmesis of the thing, and with partial breast irradiation and whole breast irradiation, it was similar. The cosmesis was similar. And this Cochrane systemic reviews, again done in 2016. The 7 studies were involved about 7,500 women, and mainly taking into consideration the outcomes, cause-specific outcomes, the distant metastasis and free survival, the relapse-free survival, loco-regional recurrence and free survival, and again the mastectomy rates. And it has been seen in all these cases, the local recurrence and the that survival was similar in both arms. And local recurrence-free survival is slightly worse in patients receiving partial breast irradiation compared to whole breast irradiation. It's just only a marginal, and the cosmos is also marginally worse for patients receiving the partial breast irradiation. But if you take that now overall survival, there was no difference at all between both the arms. The cause-specific survival do not have any difference. The distant metastasis-free survival, no difference. The relapse-free survival, again, no difference in the both arms. The loco-regional recurrence-free survival, there was no difference in both the arms. So, coming to the next methodology for giving the brachytherapy, that is the intracavitary method, and it done in a very selected cases only, and selected centers. That mainly you use the mammocyte, the accent, the contura, and the savi. That is stunt adjusted volume implants. This is a intracavitary technique. So using the mammocyte, we implant the catheter perioperatively to the lumpectomy cavity, and that is inflated. And then we can deliver the dose on the surface of the applicator, and the margins of the lumpectomy cavity get the maximum dose, and selectively you can give a higher dose to the margin of the lumpectomy cavity. So in mammocyte, what we do is the catheter is placed in the lumpectomy cavity during the procedure, operative procedure, and subsequently we inflate it by 30 to 70 ml of saline plus contrast. And after that, we do the CT planning for the dose delivery. And once the planning is completed, then we give the iridium-182 source connected via the remote control after loading, and the dose is delivered to the lumpectomy cavity on the margins. The quality of the implant assessed by the quantifying the volume of the PTV that is filled with air or the seroma fluid. Ideally, less than 10% of the fluid should be filled with the air or fluid. Minimum source to skin distance for the good cosmosis should be at least 5 to 7 millimeters. Symmetry is required for adequate dosimetry. Non-symmetrical implant, the central single source channel does not allow for the shaping of the isodose curves perpendicular to the channel axis also. That is the American Brachytherapy Society recommendations. The prescription point is 1 centimeter from the balloon surface. The American Brachytherapy Society recommends a total dose of 34 gray in 10 fractions. That is to the lumpectomy site with 1 to 2 centimeter margin when STR brachytherapy is used as the sole modality. The STR treatments of 3.4 gray are generally given in 2 fractions, separated by at least 6 hours gap. More than 90% of the CTV should receive more than 90% of the dose delivered. Yeah. Then the other technique again is the accent. Then via accent balloon is the radiolucent one, and you don't need specific contracts for this particular method. The third part of drain is for draining the seroma fluid. It uses a miniatured X-ray source to deliver low energy X-rays within the needle in the catheter, thereby mimicking SDR brachytherapy. Reduced radiation protection required for these devices due to limited penetration. It allows brachytherapy to be delivered in a non-shielded procedure room or in a regular unshielded hospital operating room. Even intraoperatively, you can do it. The limitations are not suitable for tumors in the upper inner quadrant. And it is not again suitable for small breasts, the breasts with irregular lumpectomy cavity, and that the skin cavity distance criteria is not met with, although it is the most user-friendly method for brachytherapy. Then the contura, that is the central lumen plus 4 surrounding channels to accommodate the SDR source. It allows dose flexibility. There is a vacuum port to remove the seroma fluid. it's possible to account for the asymmetric balloon placement in the cavity with respect to the central channel. And it provides reduced dose to the chest wall, heart, lungs, and the other critical structures. So that is the biggest advantage with this Contura. Then other novel methods. The permanent breast seed implants were used earlier. With radioactive seeds were used, palladium-103. It was used, and we can see definitely we can implant this low activity radiation doses, palladium, into the specific target volume can be done, and it was a permanent implant. And now it's seldom used nowadays. The other indications of breast brachytherapy. The SDR brachytherapy as a neoadjuvant radiotherapy. Interstitial SDR brachytherapy as a neoadjuvant treatment in select patients for not amenable for breast conserving treatment surgery at presentation. Initially at presentation, the patient had a locally advanced breast cancer, but it's not suitable for a breast conserving surgery. Then you go for the brachytherapy, SDR brachytherapy, and either after giving neoadjuvant chemotherapy or directly after doing the external beam radiation, then doing the breast brachytherapy, or you can straight away do the brachytherapy and then consider for the subsequently do the breast conservative treatment. Either due to initial tumor size or unavoidable breast tumor ratio. So a sequence of patients were tried with a systemic chemotherapy and high dose brachytherapy with 5 grade twice a day for 3 days, and subsequently plan for surgery or other treatment. See, this is again one of the consultants now. She has taken this study when for the postgraduate study. She has taken it in 2007 when he was a postgraduate, and we have done with for the actually locally advanced breast cancer. So initially they were not inoperable. They were inoperable. So these patients were given neoadjuvant chemotherapy. Subsequently, those cases which are operable has been operated when a breast conservative treatment, and those cases which was not operable were used the brachytherapy, and subsequently they are considered this treatment for further treatment. These are the cases in the local LABC carcinomas treated by the SDR brachytherapy, and subsequently we found these cases where we have treated locally advanced cases after neoadjuvant chemotherapy, taken up for the surgery, followed by breast conservative surgery, followed by further radiation, or those who are not suitable for surgery, they straight away given radiotherapy and the brachytherapy boost. It was been found both the arms with the surgical arm and the radiotherapy arm, the results were similar, and the long-term survival was found to be similar. Then the brachytherapy again can be used as a salvage therapy after breast conservative treatment. Actually, once you have done the breast conservative treatment, you are given the radiation and the brachytherapy. Suppose the patient has recurred in the brachytherapy area, the lumpectomy area. Subsequently, it's a localized tumor, you can do further surgical resection, and that area can be boosted further with the brachytherapy. That's a salvage technique. Then subsequently, the cases where you can do boost after whole breast irradiation. The boosting after the rationale for boost after whole breast irradiation, that is to reduce the risk of recurrence and to improve the survival rates. The standard care involves adjuvant radiotherapy after breast conserving surgery. An extra dose or the boost dose to the tumor bed because of breast cancer tends to come back in the same area where it was removed. So again, it was a satisfies physical appearance for the osmosis and important for the breast conserving therapy. So RCR recommendation for that is patients were taken below the age of 50, and those patients above 50 in grade 3 tumors or extensive ductal component. So the boost therapy either can be done with photons, we can do it with electrons. It is a superficial tumor, we can do electrons, And if it is deep-seated tumors, we prefer brachytherapy. Brachytherapy seems to be the preferred option, and patient with high risk or local recurrence, younger age, positive or close margins, or deep-seated tumors where the depth is more than 3 to 4 centimeters, we prefer to do by brachytherapy, the boost. The prognostic factors for local control in breast cancer after long-term follow-up in the ERTC, boost or no boost trials. Then a large series of patients, about 5,500 early stage breast cancer patients treated with breast conserving surgery and whole breast irradiation. They are randomized between no boost and cystine gray boost. So it was found the cumulative local recurrence probability was better in those cases where we given the local boost after the whole breast irradiation. You can see in all the series of cases. The Cochrane study, where 5 randomized clinical trials, again studies involving more than 8,000 patients, women. The endpoints were mainly the local tumor control, the survival, overall survival, the disease-free survival, the late toxicity, and the cosmosis. If you see the survival studies, we would find this all these studies favors the local boost. And it again, the local control also favors local boost. The cosmosis, again, it favors the local boost, where local boost has been given. This happens to be a patient we have treated about in 2014. She has come to the OPD for a routine checkup 2 days back. I just copied the photograph. So she was treated in 2004 by the breast conservative treatment and brachytherapy. Thank you. This is our Sangam, Nalabad, the bridge over the Yamuna. Thank you very much. And I should say, brachytherapy, a long way we have gone, and we have got a sufficient experience and dealing with the tumors in various locations, and especially in the management of breast cancer carcinoma. We can deliver high dose to the precise tumor volume, and you can achieve a very good cosmetic result. Thank you. Thank you very much.
Thank you, Dr. Paul. Such a nice presentation and overview of brachytherapy about breast cancers. And I don't know how many centers are practicing in UP. Do you have any idea who else is practicing? SRMS, I have seen people have started using it. And I don't know, SCPGI, KGMC, RML, I have no idea. But we should try to promote this interstitial implants and teach our residents and try to give training for interstitial brachytherapy and different type of brachytherapy. Is there any question from the audience?
So one question is, what is the brachytherapy boost dose?
Pardon? Excuse me, doctor.
What is brachytherapy boost dose?
Boost dose, actually.
Yeah.
That depends upon how much you are given by the external beam radiation. I have already mentioned, if you are given 45 to 50 gray, then naturally the boost dose we have seen about 3.4 gray. We are using SDR. You give twice a day for 2 days only, 4 fractions, 3.4 gray. So it depends upon the external beam, how much you are given. Compensatory, you get that tissue, the equivalent dose for the boost. They have used about 18 gray in that study. That depends upon the external beam dose.
Dr. Chaturvedi, sir? Yeah. Next question.
This is what is brachytherapy dose given during chest wall recurrence? This is from Dr. Pragya.
See, chest wall recurrence. Yeah, chest wall recurrence again. We have to give the radical dose. Once you have irradiated, the patient it may be presenting after many years. The recurrence may be after many years. Once you are using a cast with that mold with the template cast, we are using, that's a surface dose. We can give a radical dose when you are using a surface mold. That is, we are giving the mold over the surface of the tumor. We can exactly give the radical dose.
So
Because
you can,
when there is a recurrence, a radical dose has to be given. Because these are the cases where surgery is not feasible. There will be
yes, very
multiple
good.
satellite nodules. A radical dose can be delivered in these cases.
Very true.
Yeah.
Surface mold can be used, and the applicators can be put in the mold.
Yeah, on the surface.
Yeah.
We have treated, we have given the surface mold.
Correct.
And
Correct.
we are not used interstitial. Interstitial will be a little difficult in the recurrent cases where you have satellite nodules and all. But surface mold is a very good technology. And when you are doing by the SDR, it is very simple technique also. The patient there can come home daily and get the treatment and go. So procedure, the mold can be taken out and kept.
There is another question from Dr. Dibanjan Kundu. Kindly explain what is TARGIT? Target. TARGIT. Target.
Target for?
The target. He's talking about target. The thing that
Target.
was used in, yes, that thing that was used by King's Cross Hospital in London. I think there is Jayant Vaidya. You know, the one that has a sauce inside it. It has an X-ray sauce within it, and it is given in the cavity. So you operate, do a lumpectomy, and then you put this target applicator inside, and it gives a single fraction dose. He's talking about that, sir.
Okay, okay. That is a peroperative.
Peroperative. Yes, it is peroperative. Yes, sir. Yes, peroperative.
And even peroperatively, people have tried with even using electrons. People have tried peroperatively electrons delivering. People have tried to that lumpectomy cavity. So I don't know. I don't have much experience in that. Yeah.
Can I ask one practical question?
Yeah.
Sir, you are using interstitial boost therapy after BCS, no? After whole breast irradiation. So, what is the time gap between after completion of this ABRT and the starting the interstitial?
After external beam radiation, actually we'll wait for 2 to 3 weeks because there'll be skin reactions. We'll wait for the skin reaction to settle. Then we start 2 to 3 weeks only. Then we give the boost.
My second question is, sir, nowadays, as everything is changing from conventional to hyperfraction, especially in case of the BCT. So, do you find any difference or any difficulty in doing interstitial implant as a boost in this patient after receiving the hyperfractionation?
See, hyperfractionation also, there is no problem. If you have severe reactions, then only we have to wait for the reactions to settle. Otherwise, we can do that treatment in a 2 to 3 weeks gap. Only in those cases where the hyperfractionation, you find more skin reactions, grade 2 to 3 skin reactions. Then only we have to wait for the reactions to heal. Otherwise, you can do if it is the grade 2, then you can do it in 2 to 3 weeks.
Okay, sir. In long-term follow-up, any fibrosis, something difference in these patients?
See, in local treatment, because usually we don't find this fibrosis and other thing. And whatever patients we are coming to us even now, we have excellent cosmetic response. Cosmetic results are there. Like the patient I have shown you that came to me just 2 days back. So naturally she had come for a routine checkup. So they don't have any of the reactions we don't see.
Dr. Rashi, you want to say something? Dr. Rashi?
Yeah, I am. Yes, ma'am. Actually, ma'am, sir, we are doing very less number of brachytherapies in our center.
Yeah.
And this is because although we do tumor board discussion, but you know, to convince the surgeon, it becomes very difficult for us. And I think we as a radiation oncologist, you all are senior. You should ask us surgeons to give us cases so that and you can also showcase your cases. Yeah, otherwise, otherwise, in brachytherapy, it will become the surgeons don't give us cases. Although in TMF, what I have seen, they are doing so many cases. They are doing tumor board discussions on daily basis. But what happens in our center, being in private center, the cost because of cost. If it is only brachytherapy, then it is okay. And when we convert brachytherapy as a boost, then it's cost double. So this is another issue that I think so.
See, in our center, basically slightly different from TMH. All the patients come to the radiotherapy department first. And we are the ones referring to the surgery and the medical office.
Sir, you should escalate these things
See,
in our
because
centers also.
See, actually, since we were here we initiated that center and people have the confidence. People from generation wise, they're coming. We are just have people treated many years back. They come with the children with a different disease, or may not be malignancy also. And see, they have that confidence has been developed. So, but we have a good team of doctors, the surgeons also, and we always have a tumor board. We definitely regularly have a tumor board and discuss each and every case. And we decide, and in the tumor board, we decide what treatment to be done, what surgery has to be done. Once subsequently, the radiation is also to be given, we plan out in the tumor board. So we have a good coordination that has to be created in all the centers. We should also in all your centers, you have to select one or few of the surgeons and you have to have a teamwork that only will work. Otherwise, there's all surgeons practically they all send all those radical mastectomies they do. Breast conversion treatment.
Breast conservation surgeries are very common in our center.
Okay.
But, breast conservation, I think most of the patients are preferring for breast conservation surgery.
Yeah, definitely. Nowadays they're demanding it. They are demanding.
Yeah.
So I think once you have a coordination with the surgeon, we can easily work out. We can ask that surgeon to call you in the OT when they are doing the surgery. One of you or one of your juniors can go and attend, and accordingly can plan the treatment then and there.
Yes, sir.
So subsequent treatment. So a coordinated action is required. Yeah.
Dr. Paul, the problem is not there. The surgeon, they keep on chopping off everything. They are doing everything. They have got the upper hand. Unfortunately, even after doing BCS, they are not sending patient for radiation.
Yeah.
They say there is no need. And then later on, patient come with the metastasis. Local recurrence, leave aside local recurrence, they come with the metastasis and local recurrence. So they must be treated with brachytherapy and it must be stressed upon.
Yeah. Initially, I remember I showed you one slide. We have seen all the patients of BCS, about 15 to 30% have not received any additional treatment. That is because they have been not referred for treatment. The surgeon is overconfident. They have taken additional margin, adequate margin. So they have not sent for the treatment. That is the reason.
Yes, ultimately they come with the recurrence.
And
they die off. So this is very unfortunate and we are not able to. In fact, the patient do not turn up to the radiotherapist for radiation.
Actually, close follow-up is also very important.
Yeah, that is very important.
After treatment also, regular meticulous follow-up is required for all the patients. That also we are taking care of that regular follow-up, and we have a cancer registry. So they are contacting all the patients regularly, and if there's a delay in follow-up, they're getting the details and ask them to report for the follow-up.
I think we should.
Can I ask one more thing?
Yeah, ma'am.
Yes, sir. I want to ask in radiotherapy planning for brachytherapy. Can you revise? Can you again repeat a few points that I should remember when we are looking for radiotherapy planning, dose, follow-up, everything?
Yeah.
So that we can avoid complication.
We have after doing the implants, then we have to do we usually make a CT-based planning with the dummy sources inside. We do the planning, and all the images transferred to the treatment planning system. In the treatment planning system, we define the target volume and taking the sufficient margin around it. Then after doing that, defining the target volume, we decide the catheters, what the dual timing, what to be given in each catheter. Then we'll decide and get a target, the isodose distribution. And we keep on changing this plan subsequently and see the best and choose the best plan where you get the adequate margin around the target volume. Then only we choose the treatment, and it takes about a day or two for planning. So then only we do it, and when the final plan is approved by all your colleagues, then only we execute the treatment. So that meticulous planning is important, and you have to have we usually do the CT-based planning with the dummy sources. So that is transferred to the treatment planning system, and the planning is confirmed in the treatment planning system. The execution is simple. Yeah.
Dr. Shalin sir, do you want to say something?
No,
Concluding
nothing
remarks?
really. I will answer Professor Paul's, Dr. B.Paul's initial, query about whether we do brachytherapy in SGPGI. So, sir, with hypofractionation, 40 and 15, or the fast forward, which is also going on, it's about 27 gray and 5 fractions.
Yeah.
So what happens is that the further boost is then given by by defining the cavity, and it is given by either a field and field technique, or let us say, you just reduce the boost volume and you continue with the same treatment. And after giving the hypofractionated treatment, you give the boost by teletherapy. So that is what is actually done.
I know.
So that is one reason why it has fallen out of favor.
Yeah,
Now, we have, of course, done in the past, giving HDR brachytherapy, doing implants post, shall we say, we have done perioperative implants in PGI, but it somehow went out of fashion because, with the steel tubes in place, the rigid steel tubes in place and the template, transferring the patient to the patient gets the boost dose first, and then followed by the external beam radiotherapy. Or you could give, of course, external beam and then give the boost. But in that case, you are then blind, because then you see, you cannot make out the cavity. You go approximately in that area, and you've left clips behind, and you may or may not be able to cover it right. So basically, the cavity is identified on CT scan, and it is covered with a margin in the boost. And that's the reason, the main reason for the it's fallen out of favor, because it's so much easier to just do it there. Of course, you're right, you could finish the brachytherapy much faster, but teletherapy means that many more fractions. You give about 12 gray to 15 gray boost. If you had 15, 25, you give 12 gray or 15 gray boost. And if you have hypofractionating, then of course, if you're giving a 2 gray per fraction, it's different. And if you're hypofractionating, it's different.
Yeah, Dr. Shalin, see, whenever you are planning for a brachytherapy for breast implants, always, if you are not doing it perioperatively, always you should insist our surgeon to put the marker clips.
They do that,
the tumor margins.
They do that.
That's the only thing which is feasible. We can only identify the marker, accordingly design the tumor volume. That is mandatory, and you will have to insist the surgeon to put the marker at the margins. That is the only method we can define the volume. They
do that. They do that in PGI.
Yeah.
We are fortunate to have a team of surgeons who have an interest in breast cancer. Yeah.
Okay.
So that's okay. But the brachytherapy has gone out of favor for this reason.
I know. There is a loss of interest for brachytherapy in many centers, I noticed. So we are still continuing.
So.
Yeah.
Really, it's very nice. It's a good discussion. And this is my wish that...
Subriman, there are two nice questions, I think, Dr.
One question I can read here. In today's precision area, what is your opinion on SBRT versus brachytherapy in breast?
I think Dr. Shalin should answer. See, that's what the same Dr. Shalin said. We can deliver the same dose for the brachytherapy by SBRT also. Similar.
So the point is simple. Whatever be your fractionation, you see, if you are giving something by external beam radiotherapy, SBRT is obviously external beam radiotherapy, you are using a hypofractionated form. Your fraction size is not conventional. You have, there are two components of SBRT here. First is the dose per fraction is larger, and the second component is that it is highly conformal. Now, conformality is not something that is peculiar to SBRT. You have to decide your fractionation schedule, what you want to do. So I think they would be both equivalent, absolutely equivalent in terms of outcome. I am not aware. I'm not following the literature, so I will not like to comment. However, one can revert on this topic and see what is the equivalence data, and in terms of the two different fractionation schedules used, conventional fractionation following standard teletherapy, or SBRT. And of course, both need to be followed by, we're currently hyperfractionating. We're not doing 1525 anymore. We've abandoned that for the last 1 decade. And in fact, so the fraction size is in any case larger. I don't see there should be a reason to differ. There should not be any reason to differ in outcome, but in the absence of following literature, I would not want to comment on this.
See, doctor, I said in the beginning, the most conformal treatment we can give radiation is the brachytherapy.
That's
You
correct,
have a
sir.
better conformity where we can give selective radiation to the tumor volume and take into consideration all the critical structures around. There
That's
is
right,
no
sir.
other critical method for any part of the body. That is the most conformal treatment.
That's very true.
Yeah.
And you can spare the skin and critical structure very well. It can be limited to a very small area. So it's very nice. Thank you, Dr. Pal. Thank you very much. And thank
So there
you.
must be another
Thank
question,
you.
sir. There's a second question
there-
also that Dr. Surbi was talking about.
So I think there's no more question. Sir has
All right.
answered all the questions here.
All right. Okay.
So thank you, Dr. Shaleen, Dr. Paul, and Dr. Survi. Now over to you, Survi.
Thank you so much, sir. Thank you so much, Dr. Paul, sir, for such a nice elaboration. You have covered all the theoretical part as well as practical part of brachytherapy.
Yes.
I think this will be very useful for our students and as for us also. Thank you, sir. Thank you, Chaturvedi, sir, for such a nice
Thank you.
moderation.
Thank you. Thank you.
Sir. Thank you, Rashi, and thank you all the participants. Thank you so much once again.
Thank you so much.